can you give our viewers a brief background on yourself and your path to the United States?
Thank you so much for that question. So I was born and brought up in India, where I also did my high school. And in India, you do uh, a combined program of undergraduate and medical school. And that's what I was doing. So in third year of medical school, I won um, a grant from the government of India, Department of Biotechnology, to go do summer research in US. And I could choose any place, but they would basically place me in the lab. So they helped me find a place to do research in epigenetics of glioma at the University of Wisconsin-Madison Department of Neurosurgery. And while I was coming there, my research supervisor said, why don't you also do an observership in with my clinical partner, and you could get the best of both worlds. So I said, that sounds wonderful. And I did that, and I was hooked. And I think, it made me reconsider a lot of decisions. And I said, I would love to be in this kind of a situation, this kind of a role where I could combine research and clinical practice in this very integrated fashion. So I did that research in neuro-oncology, then went back home, then gave my step one when it was still a scored exam, uh, and then did my sub-internships right before I graduated, just like fourth year med students. Did one in Texas, another in Missouri, another in Kansas, and then graduated and then joined a neuro-oncology postdoctoral research fellowship in Miami. So that was, I continued there for a year.
Interesting. Okay. Well, when you started medical school, did you know that you want to pursue neurosurgery, or were there other specialties that you were more focused on, or how was the process by which you decided neurosurgery is what I want to do?
Sure. So in India, because you do a undergraduate medical school, so I started medical school at the age of 18, and I had an open mind towards all specialties, and I bounced around a bit. And I think the decision towards neurosurgery was a series of small moments and small experiences that added up cumulatively to demonstrate to me that this is the right choice and the right path for all of its holistic fashion. So I think some of the defining moments were scrub into some of the neurosurgery cases at my home program, um, seeing what we could do for our patients and the gratifying nature of the work that we do with our own hands. Another experience that cemented was the summer research that I did in 2019 in neurosurgery, and also did observership. And finally, it was fully solidified when I did the sub-internships in 2022. And after that, I've been doing neurosurgical research since graduation medical school.
Very interesting. So to follow your story, so now you did your summer internships in the United States after graduating from medical school, and then you started working at Miami after medical school in India, correct? Okay.
Yes, that is correct.
So, so you had conducted some research while you were in medical school, and that was at Wisconsin.
So I started in medical school much prior to Wisconsin, and I basically got involved with some of my faculty projects. But
Okay.
before that, actually, during first year, my parents were MD PhDs, both of them, and there isn't a lot of culture in India to have MD PhDs. Generally, you have MDs or you have PhDs. So I think growing up, I saw that a love for learning and a love for science was paramount, and I think that maybe rubbed off a little bit on me. And so I said, no, I first want to learn how to do this properly, and I think that was very helpful for me. So in first year of medical school, I said, I want to do some courses. This is the age of the internet. You can take
Hmm.
courses in anything. So I did it like a ton of courses online through various sources, went to workshops, and so for 1.5 to 2 years, I didn't actually start just dive head deep into projects. Meanwhile, I was doing research, learning the basics, learning, what is good research and what is not. And I think that is something very meaningful to do before you jump in a project and then realize 6 months later, oh, this this was a fundamental flaw that now hinders the publication and dissemination of this work. And
Yeah.
so I got involved in faculty research projects, and my neurosurgery department back home was extremely clinical. So I was involved in medicine projects, some psychiatry projects, some general surgery projects, because those were more active departments, and those were the opportunities available. Thankfully, in India, I got a chance to be part of these large multi-center studies, because so we didn't have an electronic health record. We did not have any real-world database, for example, in US that people mine the NCDB or SEER or NISS. So any project that you would do, you would basically go into the records room of the department where there were huge shelves of paper records, and you'd pull them out and then go through them manually, and you would construct an Excel flowchart and then export it. And so, as you can imagine, 80% of any research project was data collection,
Yeah.
because it was extremely hard, and there was no national registry. And as so far as I know, even the national registries that exist so far cannot be yet accessed by routine researchers at hospitals. There are
Mhm.
some cancer registries. So I wanted to be part of meaningful and impactful research beyond just reporting on some case series and case reports.
Yeah.
So I became a member of some international societies as a student member. Most of those are free. And this side tip that I would give to people watching, if you're watching from LMICs, you can utilize your student status to become a member. And once you start getting newsletters. And I kept an eye out on the newsletters, and they said, oh, we are now recruiting from this global study. And I would reach out to them and, hey, I know this study is focused in Europe, but is there a chance I could get my Indian center participate? And they would say, yeah, sure, absolutely, if you get all the approvals. So I said, oh yeah, that I can figure out. I mean, so I would do all the IRB stuff, get the local approvals. I mean, it was a very tedious process. So, but because I did it, I think I learned a lot. And then, so I can talk about two of these projects in a bit of a more greater detail. For example,
Yeah.
one through the European Society of Intensive Care Medicine is a very large and very prominent research or driven organization. And they do these large multi-center, both observational and interventional studies. So obviously I couldn't be involved in clinical trials directly as a co-investigator, but I
Right.
could be involved in international multi-center observations registries, and that's what I did. So they basically started recruiting for a study called Synapse ICU. And what they wanted to see is, do ICP monitors work? And the problem was, in high income countries, you can't really randomize people, and we'll touch on randomization and ethics later, is you can't really randomize people to get an ICP monitor after acute brain injury versus not get, because it would be
Yeah.
considered unethical by most RBs. Meanwhile, in my center, we inserted 0 patients. ICP monitors is 0 patients. So
Yeah.
it's kind of a challenge. So how do you accurately sample? So what
Mhm.
these people said, okay, we can do a very meticulous and deep matching if we get a very large sample size. And so they
Mhm.
recruited from all across the world, all countries, and they recruited over 2,500 patients of acute brain injury. So
Mhm.
and when you participate in these kinds of multi-center studies, the way they work is they say, okay, generally they have a minimum number of patients that you have to recruit, and
Mhm.
you get red cap access elsewhere. And there's something you can, I would let people know, your institution doesn't need to have red cap. Your institution doesn't need to subscribe to any software. The the sponsoring country and the sponsoring organization will give you access to these tools as a guest access, and you would feed the data online but keep all the paper records in a separate place, and you would just keep copies for future audits and validation.
Mhm.
And you would generally have a mini team. You have a mini team of 3 or 4 or 5 people per center, and all of them, they get collaboratorship. So, and that's something I want to again go on a tangent on, is collaboratorship is a different model from co-authorship. Here, rather than being confined by having, for example, 10 authors or 20 authors, often many journals state more than 30 authors, and it's not possible. Many even have 6 for research letters or stuff like that, is you
Mhm.
say we can even have like more than 500 collaborators. So this model works really well if you want to get involved, but you don't have the wherewithal to do this in large global study, but also want to contribute. And so I got involved in teams, and we would have a team lead. So in this Synapse ICU study, we recruited a bunch of patients, and because it was all observational, so consent was easy, randomization was easy. I was the primary person driving them, and then I had a faculty member. And so we submit the data. And this is one nice part when you participate in these large multi-center studies as a trainee. As a trainee, what you have is the luxury of time. But what you don't have is the expert knowledge of, do I need to construct a multi-level model? How do I
Mm-hmm.
stratify the data appropriately? How do I make sure that my analytical assumptions are appropriate? These come through years and years of modeling, through years and years of, epidemiological drawing DAGs. And this is not something that medical students or perhaps even residents find it easy. And I find it hard. Having undergone through formal education, I still struggle with it after more than nearly a number of papers. So, and I realized, okay, I'm going to work on the operational aspects, get the data in as a local center from India. So we submit the local center from India, and that's where our job ends for this multi-center study. Those guys, they were sitting in an Italian university, and their boss was a person who has been a leader in intensive care medicine in the world, and they analyze the data, they write up the paper, we get to review and give our comments, and then finally it goes to Lancet Neurology. And at the time before COVID, Lancet Neurology had over 40 impact factor. And
Mm-hmm.
so as a trainee, I saw, wow, this is an incredible model. Meanwhile, if I were to, work for months in my setting, I'm producing data and a publication, one that is not very considered very professionally meaningful from a CV standpoint, but also from a science standpoint. I'm just contributing to yet another paper. And what does that paper? It just does nothing. It's just a case series of some single surgeon. So meanwhile, this work, it had over 400, 500 authors, but what they demonstrated is you can do very rigorous modeling and you can decrease mortality by 15 percentage point by inserting an ICP monitor. And these effects were pronounced in low middle income countries. Now that is a very, very powerful finding. And because they had a huge sample size, they had a very pre-specified analytical plan, and it does lead to very rigorous conclusions, and that
Mm-hmm.
lends that touches base into causal inference. So, and I would encourage, if you are in institutions where your research opportunities are limited, you can always be involved in larger, bigger research projects where you might not be the person driving the entire thing, you might not have the resources or the wherewithal, but you can still contribute meaningfully and in something that also benefits you professionally.
Let's dig a little bit deeper into the process here. So you had signed up for these organizations and you were getting emails. And so when you would see an email about a project that you thought was a possibility, you would reach out and offer to be like a site leader, essentially. So is that common in the United States as well? So if we're talking to DO students who might not have a neurosurgery department in the US, or maybe a MD student from a school without a neurosurgery program or a small program without a residency program, um, do those things still happen in the United States, or is that something that's more likely to occur in other countries at the moment?
Thank you. And that's a great question. So there are two sides to this coin. One is the operational logistics and the compliance side of it. So from my standpoint, what I would serve as, a contact person. I would tell them, hey, I'm going to be the contact person for this site, but the actual site leader is going to be a faculty member for compliance purposes, and they
Right,
would
right, right.
oversee and supervise. But what would happen is I would have these discussions, get all the brochures, get all the protocol, get everything ready, and then approach them. Hey, just, you won't have to do a lot of work. I know you're super clinically busy, but you'll have to just sign on the dotted line, just supervise and just take a look. And hey, this is what we're doing. It's very clearly laid out. So that's one nice part. When you get involved in these larger projects, there's a lot of uniformity and standardization that is done because they want, you know, very homogeneous data
Yeah,
collection procedures. And
yeah.
you would have standard operating procedures and manuals, and you can always reach out. So you are not the person, okay, should I do this or X? Should I do this? I could always reach out. So from a compliance standpoint, that's something for sure DO students and even MD students at newer schools that are just being established, many of those across the country, can be involved in. So how does it look like from an IRB standpoint? Actually, if this is not a clinical trial, the problem comes is how your IRB perceives this transmission of US de-identified data to to, for example, a European, red cap hosting. That is, I
Mhm.
think, the hard part. And I think many organizations have become much more reasonable in this regard. And many IRBs
Mhm.
realized, oh, this is
Yeah.
something commonly done, and this is de-identified. You create when you click a new record in RedCap, and it generates an ID, and that ID you note down on the physical patient record in your own
Mhm.
list that you keep at your own institution. What they only have is a RedCap ID,
Yeah.
but they can reach out and correspond using the RedCap ID. So actually, the process of the risk of de-identification isn't actually of identification isn't that much, and there is a lot of confidentiality and privacy, and RedCap is HIPAA compliant. So all of those, but the problem is the IRBs sometimes are slightly reluctant.
Yeah.
Other part is cultural, and this is something I've seen is in US, because often a lot of schools have their own institution, have their own um, departments and resources. So it comes across as you would, if you would propose this to people and they were like, why would I be not a co-author and be a collaborator when I can publish my own paper in, for example, Journal of Neurosurgery or World Neurosurgery? And that, and I think that is a culture we and I say this with a degree of humility as somebody just entering the field. Maybe we need to think about, okay, all these papers that are being published, what is the impact? Meanwhile,
Mhm.
rather than having 10 papers in, in journals that are being published here in one year surgery, can we contribute to one paper that actually changes practice? For
Yeah.
example, a case in point is there are hundred. I was just looking at prediction. If you just search prediction models neurosurgery, there are hundreds of prediction models. But my back of the envelope calculation is more than 90% of them have never seen any usage except just being cited in some review articles or
Yeah.
cited by future prediction models. So
Yep. Mhm.
and that is a common thing. And this is something I realized after doing a lot of research is, what am I actually contributing? I'm not changing policy. I'm not, contributing to changing clinical practice. All I'm just doing is describing some institutional work that people cite academically, but has no dent on actual practice and policy.
So let's dig into that. So we have people who watch this of varying backgrounds. So some people might say, um, depending on somebody's background with their knowledge of epidemiology and biostats, somebody might ask the fundamental question of what's wrong with doing a case series at a single institution? Why is doing a multi-center observational study with more patients better? So let's discuss that at a very fundamental level. Why is it the case that a case series? I mean, because if it's a 10,000 patients, there's tons of different surgeons operating. They're operating under very different environments, different countries, different patient populations, different skill levels. All of these things are confounders, meaning that they might influence the outcome. Um, why is the single series worse than the larger multi-center observational data set?
Sure, sure, absolutely. So, and we come to the very basic point of validity. When we say that X causes Y, we are inferring causality. When we write in a case series that XY technique may be a very reasonable option for Z cases, we are inferring causality there. And causality is hard to determine. If you, for example, do a case with a certain technique, it's a new technique, for example. Let's walk through this in deeper fashion. You have a certain new device and your supervising surgeon is excited, or if you're a trainee, you are excited to put it and try it out in the patient, and it's FDA approved and all, of course. But you want to see how do patients differ with this technique versus the older techniques. What if you just what if you do not have a control arm? Then how can you estimate what additional benefit that this device or this technique provide beyond a certain level of baseline things? So the first baseline thing is the placebo effect. We know it is very significant. In spine surgery, it is even more significant. It is estimated to be nearly 30 to 50% of any effect size that we measure with any surgery. It has been seen that when we do sham controlled uh, trials of spinal cord stimulators, they perform equally as well as actual device implantation. So the placebo effect is very strong, and it's stronger the more invasive surgery you do, the more high acuity surgery you do. the more sick the patient is, the placebo effect is actually stronger. So that's
Wow.
one, the placebo effect. And it's incredible. It's mind-boggling once you realize, wow, this is wow. How can I attribute my technique did the benefit when you have all this? The second thing is that stacks on top of the placebo effect is the is selection bias. When you
Mhm.
are doing any new technique, you are always very careful with that technique. You're always slower. You're always, you don't select the patients who are crashing. You don't select the patients who are likely to do bad. And that's something we implicitly do. We didn't, we don't as as people who are interested in doing neurosurgery or any surgical specialty, and people who are doing this, we don't want let me that we don't want to bias our own results. Unfortunately, it happens implicitly because we do this kind of selection. So that adds on top of this, we are taking healthier, more fitter patients, people with less severe pathologies. Then on top of that, we add the benefits of routine care. So, for example, when people write about neurosurgical approaches, oh, we did this approach and it's very safe and feasible. But you did all of these. There was just one small, drop in the bucket of so many other things that you did. Then you stack on top of it. So you have these three major, you know, stacked bars that have stacked. And now you want to determine what proportion of the effect was actually due to my technique, my approach. That is a very difficult question unless you
Mhm.
have first and foremost a control arm. Without a control arm, you can never actually subtract the effect. So that lends itself to, if you don't have a control arm, you have a problem. And let me be the first to say I have participated in studies and I have contributed to papers that did not have a control arm. So how much can we ascribe validity to our conclusions? It's actually very little in the absence of a control arm.
Yes. So when is it appropriate to do a case series then?
Sure. And I think uh, I again say this with a degree of humility. A case series is a very reasonable tool to demonstrate initial feasibility, to say, okay, this may be a feasible approach, but we need to look to other specialties and how they conclude when they do their initial case series. And that's something surgery has not adopted, or
Mhm.
more particularly neurosurgery. For example, when cardiology does their new device implantation, of course they do it in a couple of patients, and then they do a phase one, a phase one, a phase two, and a phase three trial. So
Mhm.
this so a case series may be very reasonable if you have just perfected a new technique, you want to report the initial result, just create some dissemination. But I believe it is unreasonable to conclude that now this is safe and appropriate for this pathology.
Mhm.
You don't know about the safety and efficacy. All you've demonstrated is feasibility, that yes,
Mhm.
we can, it's feasible to, but we need a controlled comparison. That's the
Mhm.
next thing that you should come. Okay, so once you have done a controlled comparison, now what? Now we come to confounding. And that is like the boogaloo, the bugbear in all of research and all of what we do in neurosurgery is confounding. It's
Mhm.
such so painful, so difficult. Is how do we separate out the this convoluted relationship between the intervention and the outcome when there are additional variables that impact both intervention and the outcome.
Mhm.
So then the case builds up slowly for randomized controlled trials. And uh, the other thing which I think case reports are is quite reasonable is educational in value. And I applaud the Journal of
Mhm.
Neurosurgery case lessons, is they're trying to create a lot of common cases that we do, a lot of cases
Absolutely.
that we do in, and there are variations on people's techniques slightly and how people do the case, but reporting it from start to finish in one case, reported very well with illustrations, is actually a very meaningful endeavor.
Yeah.
And I applaud, Dr. Rutka for spearheading this initiative. So
Yeah.
the educational content is increased. That's 100%.
Yes. It's feasible to have a control arm and observational study, and you can also have a control arm and a randomized control trial. Why is the randomized control trial considered to be um, a more rigorous study design than the observational study, given that both you can have a control arm in both?
Sure, absolutely. And this lends itself to basic probability and logic and the concept of the counterfactual. So let's explain what a counterfactual is. Imagine you and I, we're sitting down, we after this chat, you drink a cup of coffee and then you go throughout your day. How do you ascribe the benefit the coffee had to you in an alternate universe where you did not drink the coffee? So think of it as a multiverse. There are multiple universes happening. In one universe, you drank the coffee after a Zoom call. In another universe, you never drank the coffee. And if you were to subtract your productivity throughout the day in this universe versus the other universe, you would arrive at the actual benefit of the coffee. And this alternative circumstance where everything remained the same except you drinking coffee is the counterfactual.
Mm-hmm.
This is the fundamental argument about when we go from an intervention or an exposure to an outcome is we are trying to approximate the counterfactual. Now in reality, because in our any biomedical research, it would be amazing if it could create a true counterfactual. So rather
Mm-hmm.
we try to approximate the counterfactual, and we could do it in multiple ways. The best possible way that we realized and have discovered is randomization. It's such a powerful tool. And interestingly, one of the earliest reported uses of a controlled trial, not a true randomization, but a quasi randomization, is uh, is uh, is the use of vitamin C for the treatment of scurvy. And actually, the captain, he divided the sailors into two groups, and one he gave vitamin C, and another he did not give citrusy fruits containing vitamin C. So, and that led to a very clear signal of benefit.
Mm-hmm.
So, so when we what does randomization accomplish? So there are several things that people have stated that randomization accomplishes, and you can look at it in various ways. The first thing it does, if randomization, and that's always a disclaimer that has to be done, if randomization is achieved successfully, then it ensures both the groups which are due to receive the intervention are as likely to have the outcome in the absence of the intervention.
Mm-hmm.
They both have the same probability. Now, this gets manifested in a couple of ways. Some people call it covariate balance, but
Mm-hmm.
covariate balance is one small lens or one small domain of it. And how do we assess or see covariate balances? For example, we create a table one, a table of demographic characteristics. In any example, you would look at an NEJM paper, and they would describe, okay, these many people were male in this group, these many were male in another group, these many received radiotherapy in this group, this many had received radiotherapy in another group. And so this is one thing that randomization does, is it makes sure the probability of having the outcome of interest is similar in both groups in the absence of the intervention in the intervention. And we are very close to approximating the counterfactual if we do a randomization well. But this holds true at the start of randomization, at the time of randomization, at baseline. But then certain things happen which lead to deviation from randomization, which we can maybe talk about later. The other thing that randomization does is it or achieves is it balances known and unknown confounders. When we do an observational study, we could come up with the argument. So what? I could also get a control group, and I could perhaps, draw a table one and, put all the things that, we know are meaningful and, put them all there, and we could, balance them out. And we have a couple of strategies. We could do propensity score matching. We could do inverse probability of treatment weighting. And
Mm-hmm.
there are several approaches. We could do quotient exact matching, Fisher's matching. Um, but all of what that is restricted by or constrained by the fact that you can only make groups similar across variables where you have collected the data on. And it's humanly not possible to collect data on all variables. There are so many variables that we now know so much about social determinants of health. But do
Mm-hmm.
we see people being matched, for example, on the kind of house they live in? It's a very hard thing to match on. We
Yeah.
cannot match people on the kind of marriage they have, but we know from social sciences and anthropology that if you have a happy marriage and you have a spouse that you're happily married to versus if you are divorced or you're single or living alone, you have much poorer outcomes. You have no caregiver versus you have a spouse that is caring for you. And that I would actually say we know from oncology, we know from other specialties that has a larger effect size than many of our drugs, many of our radiotherapies, and many of our even surgeries.
It's
So
incredible. Yeah.
yes, so that is a fundamental problem. In observation studies, we can match on the clinical variables. We can maybe extend and ask patients, okay, can you give me your zip code? And I can match on the zip code. But how do I go inside their house and see, oh, you have lead paint. Oh, you always eat junk food. Oh, so that is very
Yeah.
hard. So,
Yeah.
but it is the beauty of randomization.
Yeah.
By this incredible statistical design, what we can do is we don't need to know about all these confounders. If we do this randomization well and appropriately, we are we are reasonably certain that the groups are similar as much as possible.
Okay, so this brings me to the next question. So Dr. Harbaugh, who is the chair at Penn State, for the listener, um, he had mentioned how difficult it is to do randomized control trials in neurosurgery, and had even mentioned the fact that maybe the future of neurosurgery research are multi-center observational data sets where Bayesian approaches might be used, and the prior probability could be, you could build in the fact that it's an observational study into the prior probability. Um, for the listener, a Bayesian approach is just it's variation of statistical techniques. The main point is the difficulty of randomized control trials in neurosurgery, or in surgery in general. So could you walk through what those difficulties are? Why is it hard to do randomized control trial in surgery? And what are the ways that surgeons have thought through these issues? And along with that, are there more rigorous and less rigorous ways to do the randomized control trials in surgery?
So let's take the first question, the hard question. Why is it so difficult to do randomized clinical trials in your surgery? And I'm going to reframe this. Why is it so hard to do randomized controlled trials in neurosurgery in the US setting? And that is the
Okay.
hard, that is the main question, that the crux of the question. And the, and my views on this have been informed through two settings. One, by conducting research in low middle income country settings,
Hmm.
and also having supervisors and professors. For example, I am doing another Master of Science in Evidence-Based Healthcare from Oxford, and it's a part-time program. So the other strong influence has been Dr. Norman Faust, who has been one of the leading bioethicists in the world. And he was for a long time at University of Wisconsin-Madison, but also gave lectures at Johns Hopkins, which I took.
Hmm.
So why is it so hard in the US? There are two primary drivers of this. Let's tease them out. The first is the regulatory, administrative, and compliance burden. It is incredible. I, as a postdoctoral research fellow in neuro-oncology and neurosurgery in Miami, as part of actually quite a nimble organization. It was Baptist Health South Florida. We had a new cancer center. We had incredible staff, and we were actually more nimble than larger, more traditional, more organizations. But yet, the cost of enrolling one patient in the trial crossed nearly $20,000. And that's something lot of trainees are not aware of. So, and that's only true for the US. Meanwhile, I know that there are countries in the Nordic area, for example, uh, Denmark, they can randomize and enroll participants at a cost of less than $500 per patient. Now, that is an order of magnitude. So, and imagine I was writing a budget for one of the trials that my supervisor wanted to do. So I was writing the protocol, and I asked him, okay, can you break down the budget for me? And I'm writing for 200 patients, I'm writing a budget of $3 million. I said, this doesn't seem right. This is a very inefficient way to do this. These patients are getting all the standard of care. We are just giving one drug more to one trial arm group. But we have to comply with so many audits, so much regulatory burden. But it's not, when I saw part of this, we have to hire CROs because there's so much burden. but it's not clear to me that we are actually benefiting patients. Are we really protecting patients by doing all this effort? And we and this is a view by bioethics leaders in the United States, is that from a bioethics standpoint, all this regulatory burden is not actually for patient benefit. It's
Mhm.
just, you know, uh, uh, protecting individuals from litigation.
Mhm.
And
Mhm.
so it is neither helping the investigators, neither helping the patient. It's helping certain companies, helping the clinical research organizations, which have made a ton, millions to billions of dollars of money just running trials. And because
Yeah.
they say, okay, we need this much amount of money to do this. And now there are additional, and people keep adding on more organizations and more certifications. And now the clinical trial research nurse has to be certified, the staff has to be certified, every person has a certain certification, they have to renew it every 2 years. So all these costs add up. And so we need to look, we in the United States, we need to look outside and say, why are we paying so much for something that can be done so cheaply in Switzerland? You know, I understand, the argument may not be made for India, but for Switzerland, they have comparing GDP per capita, comparing the cost of, the cost of the standard of medical care, the cost required, but they do it very well. And so first, a degree of humility here is required. Second aspect is the bioethics standpoint of it, and is we can continue to operate under the paradigm that's unethical to randomize and have poor evidence. And 15 years pass by and we still have poor evidence. Or we can do the trial and arrive at a strong, rigorous conclusions that either something works or does not work, whether we analyze it through a Bayesian design, whether we have a frequentist approach. So I would recommend viewers to read a book called Ending Medical Reversal by a guy called Dr. Vinay Prasad. Um, and I would like, if you are watching this and you have certain views and certain on some of his commentaries, I would encourage you to separate them out from the substance, the meat of the book. And that has been a very influential, looking at how many interventions that we thought were very meaningful and then that failed, and how many patients were harmed in the process is shocking. For example, if we take a look at Vioxx, which is celecoxib, and rofecoxib, which were two drugs which are selective COX inhibitors, which were given um, for patients with pain, with joint pains and musculoskeletal pains. But the mortality was so much higher that the FDA was forced to withdraw the drug after it had approved it, after 1,000, and people later meta-analyzed and calculated how much deaths could have been prevented if we had actually done a trial beforehand, and those were in the thousands. It's really unfortunate that so much unwanted deaths occurred because we did interventions but we did not have evidence. So there is an ethical case to be made that we need to arrive at strong, rigorous conclusions through randomized controlled trials, especially interventions that we do routinely. And we keep saying, it's not so appropriate. There's so much institutional variation. We cannot ethically randomize them. So I would, for example, point out viewers to a new paper that was just published in the NEJM last year called the Rescue ASDH paper. And the trial compared decompressive craniectomy versus craniotomy for acute subdural hematoma. And it was actually led by neurosurgical trainees. And they have formed a group in UK called the British Neurosurgical Trainee Research Collaborative. And this is a large group, and people at individual centers participate as collaborators, and all of them get listed as collaborators. And what this trial did is, rather than uh, continue to do individual and single institutional case series, they said, let's randomize patients with acute subdural hematoma to decompressive craniectomy versus craniotomy, where if you either replace the bone flap or you don't replace the bone flap. And if you don't replace the bone flap, the theoretical argument is that it may prevent intracranial hypertension. And actually, they recruited quite fast, and they recruited over 450 patients, and they found that among patients with traumatic acute SDH who underwent these two approaches, there was similar disability and similar quality of life outcomes. Additional surgery was performed in higher proportion of individuals in the craniotomy group, but there were also more wound complications in the craniectomy group. So, and these are sobering findings. We hold these paradigms, these dogmas that have percolated down years and years of training. And it's important that we now take a hard, careful look at these things that we do and ask, do we really benefit patients when we do these interventions? And that is something that has, for example, has been an eye-opener, for example, how many patients were getting fusion. So there was an era where patients were getting very indiscriminate fusions and long segment fusions, but people realized, small trials were done. And Dr. Gogawala, for example, has led some of the seminal RCTs in spine surgery, and which have demonstrated, for example, you know, evidence related to fusion, evidence related to how long of a fusion should you do, and is a fusion even required? And I think we can we can learn humility also from looking at other specialties. And another, for example, one argument that is commonly made in neurosurgery is, okay, our patients are sicker, they arrive in the emergency room, and it's so hard to randomize patients. But we could, for example, implement registry-based randomization. We could implement randomization in the electronic health record. There is very clear equipoise. It is not unethical to randomize patients to one uh, uh, approach or the other approach based on an EHR-based randomization. And those techniques are available, and actually they're being utilized. Our cardiology colleagues, our oncology, cardiology, they randomize thousands of patients, and they arrive at very meticulous analyses and very rigorous conclusions that support their interventions. For example, and meanwhile, they are restricted by the time. They also have a door to balloon time. They have a door to needle time. Despite this, and those metrics driving these numbers, door to needle time, are actually, they have a lot more pressure from the compliance side to achieve very high door to, very small door to needle times. But they're still able to do these trials. And maybe we can look to them and ask them, how do you do it? We have data safety and monitoring committees. We have steering committees of trials. Let's expand our domain. Let's get innovative trial design experts involved, for example, Frank Harrell, or for example, Stephen Sen. These people who can help us utilize our time and resources more efficiently. Let's get a cardiologist on board. Let's get, for example, Deepak Bhatt on board on one of the trials and ask them, how can we look at this workflow? How can we make this more efficient that also complies with IRB and regulatory guidelines? And so far, we can do this if we choose as a field to decide that we can do so. And I again say this with a degree of humility, and certainly is that it is not so unreasonable. It's not so hard to do this once we say, okay. The other aspect where actually things can move forward is we can, which ties into my previous point of, small incremental projects that don't contribute versus a one major project and one major research endeavor that changes practice, is trainees forming collaboratives. That has not happened in US neurosurgery. We can form local collaboratives. There are already research collaboratives. For example, there is a Big Ten Research Consortium that year. There is a Northeast Research Consortium. There are research consortia supported by the NCI. For example, I have participated in two major trials and in their publication dissemination of the Adult Brain Tumor Consortium. And if we are part of trials, these research consortia, we have several benefits that we have. One, not one trainee has to pull all their weight in to drive a trial or a large registry. The other thing is that we are much more likely to get funding. The funding rates at the NIH have now dipped below 20% for all the relevant study sections. And it's hard. It's hard to write that R01 grant. It's hard to write that K01 grant. Let's build and use these existing, this research consortia and trainee research consortia. There are so many trainee research grants that we can target if we build these consortia. So that is one aspect. The second aspect is if we build these research consortia, we can move away and from the co-author model to collaborator model and say, there is only going to be one listed co-author, which is the XYZ investigators group. And under them, every single person who has been a part of this work will be listed as a collaborator, you will all be PubMed indexed. And that is something that there's a person called Anil Bhangu at University of Birmingham has led, and he has actually done the largest surgical RCTs in the world. And I participate in some of those RCTs. So one of the those two are the Global Surge and the COVID Surge projects. And they basically demonstrated that if you get COVID, you need to wait a certain amount of weeks to avoid pulmonary complications. If you, if you, if you, based on the surgical patient, this is the benefit that you get if you get vaccination. So what is the timing of surgery after you get COVID vaccination? These were critical questions, but were hard to target. And they basically were able to enroll hundreds to thousands of patients in there. So one of the papers that they published in, I think, the Lancet or Anesthesia, they had over 2,000 collaborators, one of the largest. So, but once we let go of these artificial restrictions, these constraints, then we can tackle meaningful projects, and we can actually drive the field forward rather than getting more lines in our CV.
Everybody who's watching this is probably aware of the arms race that's going on with neurosurgery, residency selection, specifically research. And the incentives are such that it does seem like if you had the choice between working on 10 projects that are smaller or one project that is larger, that you would choose to do 10 projects which are smaller. And so it will be interesting to see how these incentives play out over time. Because you're right, a lot of times when you talk to people in neurosurgery, especially people who've been in neurosurgery for a while, you do hear complaints that many papers don't change their practice because the bar to actually change practice is quite high. And as you were saying earlier, the randomized controlled trials, the large multi-center studies, those, you're able to be more precise in the effect, and you're able to trust it more due to the nature of the design of the study. So I am very curious to see how that plays out over the next 10, 20 years, especially as the residency selection process changes. Because my hypothesis that if people start learning certain ways of conducting research from day one, they might be inflexible to change thereafter because you get into the process of it, and it might be hard to change patterns of behavior later on after you've been doing it for 5, 10 years. And that brings me to another question. So you had mentioned earlier these multi-center studies and how you had signed up for these emails. So what are some of the organizations that students can look into and sign up for?
Absolutely. So as one of my primary site of involvement was the European Society of Intensive Care Medicine, and they have a very large page where they list all the available studies that people can participate in with the geographic restrictions, with restrictions related to whether or not a certain intervention is available with regards to funding. Another source is the looking to the UK. Unfortunately, I'm not aware of any US-based organization that is willing and is currently involving trainees directly and formally as an organization. And it's a huge untapped resource. We have 4 years of medical schools and 7 years of residence. That's 11 years that somebody could contribute in a very meaningful capacity and in a longitudinal fashion. You may not even stay at one practice or one place for 7 years as an assistant professor or faculty or a practicing clinician, but you are going to be there most likely for 7 years of residency. And you can actually follow, if you, for example, got involved in a study in your year 1 or year 2, you could actually provide 5-year outcomes for that patient. And that is incredible. And here in US, you have these phone numbers, you have the social security number, you have ways and means that you can track outcomes of patients through directly or indirectly. The other possibility is you become involved in some smaller US-based organizations that are interested in multi-center efforts. So I would encourage viewers to visit one of the prior episodes with Dr. Osman bin Al-Amr, who was working at University of Pittsburgh, and he was involved with one of the legends of neurosurgery, Dr. Dave Lunsford and Dr. Ajay Niranjan. And those individuals have driven an organization called the International Radiosurgery Research Foundation. And the IRRF is very interested in gathering data from across centers. So the way IRF works, one of the investigators or centers who is a part of IRRF, they propose an idea. they create a data collection flowchart and they send it out. They give it to the IRF, and the IRF circulates it to its members in the US and beyond the US. And talk to, for example, individuals. If you, for example, you have a neuro-oncological surgeon or a radio surgeon, talk to them and say, maybe we can get involved in some of the IRF efforts. So the institution that I was at Baptist Health South Florida, we are the primary coordinating site for all international research efforts of IRF. And they, for example, one some of the very meaningful studies that they have been able to carry out without actual funding, without funding to give to individual centers, has been very surprising. And so often, it's harder to go through some bigger organizations where there's a lot of levels to go through. Some smaller organizations are much nimbler. ISRS is another one. They have been which has been open to doing these multi-center collaborative efforts. The other thing is we can also think about, so there are some groups that have started working on the nerve research group is one great example, which has started collaborating, and individuals at different institutions can work with their supervisors to drive a project to execution. So the lack of funding is actually a good thing. It is a blessing. It reduces so much regulatory burden. For that $20,000 you get from a sponsor or some a academic site, there's so much paperwork involved. It's actually faster and easier to just do it without funding.
Very interesting. Very interesting. Okay, let's have this be the last question because I think we're at about an hour now. So let's say a student's initially getting interested in research. Let's say they're a first year medical student. They're fairly busy, but they have some time. In your case, you did 2 years of education on research and statistics, on methodology and statistics before getting involved with formal research studies. Let's say this person is wanting to get involved as soon as they can, but they want to learn how to conduct good research. They want to learn about biostatistics. They want to learn about methodology. Where would you tell them to start? So let's take it through like the very initial stages of learning these things and then ways of advancing that knowledge over time, besides just working on projects themselves. So maybe it's YouTube channels, maybe it's books, maybe it's anything that you think. If you were advising somebody in that position, what would you tell them?
Sure, absolutely. So if you're just starting out, you have no idea, you want to get involved. First, start with 2 books. How to Read a Paper by Trisha Greenhalgh. So she is a world leader in epidemiology, biostatistics, and good research methods. And this book has come out of UK and is actually mandatory reading at many universities. The other is Designing Clinical Research by it's in 4th edition. And the book was, let me look it up. By Stephen B. Hulley, who was part of the NIH and led one of its divisions and teams on clinical research for a long time. Those are very easy and very cheap and simple resources that you could start getting. And they're actually very readable books. Those are, I think. Now, okay, so now you want to do research and your interest is big, you have some understanding of methods. Where do you go next? The next thing I would say, get involved in a course rather than going through a YouTube channel, and start with a free course. I came from a low middle income country, so I always say, okay, what's the cheaper alternative? I can never afford, when I was in India, those kinds of very expensive courses. So the NIH has a very wonderful course called the Introduction to Principles and Practice of Clinical Research, IPPCR. It has been running for decades, and the course is offered for free throughout the year. And you can go through the series of lectures from NIH experts and experts beyond NIH that talks about research. It's a bit slightly advanced beyond, because it doesn't talk about, okay, it doesn't start with what is a p-value, but goes more about designing clinical research, the logistics, the workflow, the implementation, the analysis. And it's free. That's the best part. You can do it on your own time. Now you have done that. You said, no, I want to obtain education in this that is directed, that is focused, and I want to make a dent. then I would encourage you to look at your own institution. Most of the institutions these days have some element of either a clinical translational science center, or they might have an MS in clinical research. They might have either a certificate in clinical research or a research track. And actually, even if you are in the middle of the school program, you can still reach out to them and ask, hey, I'm interested in the research track. Is it still possible I could get that designated? Or, I have been accepted to this pathway, but could I tack on this certificate? And I'll tell you, this kind of, you cannot replace trial and error based learning with formal education
Yeah.
completely. Yes,
Yeah.
you can learn how to use data. Yes, you can teach yourself and input all the CSV file into ChatGPT and tell ChatGPT, analyze this. Sure, you can do that, but you will have no understanding of whether the hardest part about research is the assumptions. The
Yeah.
assumptions is what you need formal education for. Are my assumptions valid? When I do this analysis, is this analysis appropriate? And that's true even for R. If you run some regression in R will spit out the result. You can always report it. But if you never checked the validity of the assumptions that go into a regression model, then you fundamentally think about what kind of work that you are putting out into the world beyond something on the line of your CV. And that's something I've become more and more cognizant of. And I'll be the first to say that, I've not done so great research when I was starting out. We don't do, and that's okay. But we need to make a constant effort to improve ourselves. So doing this formal education through degree will give you some background in epidemiology, through some background in causal inference, which is a bigger deal now than was ever before, and in biostatistics. So the focus these days is now not on formula, it's on appropriateness of analyses. When are certain analyses warranted and when those are not? And I have done both. I have been involved in courses and workshops that were asynchronous, and have been involved in that were full-time and synchronous. It will always encourage individuals to go for synchronous if at all possible. This is always going to be less exciting than scrubbing into aneurysm clipping, 100%.
Yeah.
It's going to be boring, but all the good things in life and hard things in life are boring, and that's okay. And
Sure.
but if you go through these, and so other degrees that you could, for example, turn to is an MPH in epibiostats. You could do an MS in epibiostats. One course that I would give a shout out to is the MSc in evidence-based healthcare. There are also MScs in clinical research being done across. But if you're a part of an institution, the good part is if you do it as part of that same institution, you can actually get a lot of credits covered, because through some of the elective courses and other courses, through courses that you're already doing in medical school. So that's one benefit, and why I encourage people to do them. And once you just do 1 year of formal education, your mindset and your approach towards research will be so drastically different. This is one reason why. When I started my MPH, I already had 50 plus papers, but I did not need to do, from just an application standpoint, another more education. But I said, no, am I really sure? Are my analysis valid? Is the work that I'm doing, does it hold up?
Thanks for watching and being a part of this journey to improve brain and spine health around the world. If you found this video helpful, please give it a like, share it with someone who might benefit, and subscribe to our channel for more free educational content. And if you believe in our mission, visit brainandspinegroup.org to make a donation today.